From the Gert Boyle studio at OPB, this is Think Out Loud. I'm Dave Miller. As we heard not long ago in a conversation with Investigate West reporter Kaylee Tournay, Oregon data shows that mental health conditions and substance use disorder were the leading causes of recent pregnancy-related deaths. Meanwhile, a study from OHSU found not long ago that the rate of opioid use during pregnancy has more than doubled over the last decade. But people with substance use disorder are often reluctant to seek prenatal care due to stigma around their addiction. And drug treatment centers often turn away pregnant patients due to potential health risks. Efforts like Project Nurture and Nurture Oregon aim to address this by combining behavioral health and perinatal care. Diana Smith is a certified nurse midwife who works for Project Nurture. Sarah Bovee is a peer mentor and doula for Project Nurture. They both join me now. It's great to have both of you on Think Out Loud.
Thanks so much. Happy to be here.
Sarah, first, my understanding is you have 4 children ranging in age from 4 to 26. And from what I've read, their births were very different depending on what had been going on in your life at the time, and in particular, if whether or not you were in active addiction in those times. Can you tell us about your most recent pregnancy? First of all, what was your prenatal care like?
In 2020, I got pregnant. It was during COVID. So it was hard for me to access prenatal care during that time, but also in my active addiction, it made it even harder. The stigma internally and stigma externally made it really hard for me to access those supports.
So, I mean, what prevented you from accessing support? And what were your fears maybe for what would happen if you went in for a prenatal care visit?
Well, for one, just the active addiction challenges of being able to get to a clinic, of knowing that I'm in the midst of my addiction and to opiates at that time, and that was just hard for me to stop, and just the shame around all of that. I was able to access prenatal care when I had support, when I had connected with a harm reduction doula in Seattle.
What were your hopes, given all that, for what your birth would be like?
Personally, because I had been through the system before and had also had a significant time in recovery and jumping through the hoops of the child welfare system and succeeding, I knew that this was an opportune time for me to be able to access the medical care that I needed. But that didn't mean that I wasn't afraid. But I knew that if I accessed those resources and I did the next indicated step and did what was best for my child, that I'd be able to parent.
Can you tell us about the birth?
Yeah, I showed up there at the hospital, and I had my baby, and afterwards I had experienced some stigma that ended up in some after-birth trauma that left me in the hospital for 21 days. During that time, I was connected to treatment. I was connected to addiction medicine providers. They stabilized me on buprenorphine. But the experience was scary, to say the least. I did share a lot about it in other settings and in that article that you referenced.
And the gist is that from your perspective, the symptoms you were experiencing immediately post-birth were not taken seriously in your mind because you were just seen as an addict who as opposed to somebody who was dealing with a serious medical situation. And then enough time went by that it became more serious because healthcare professionals, in your telling, didn't take your actual medical concerns seriously. Is that a fair way to summarize it?
Yeah, I felt some pressure and had brought that to the attention of my care team, and they thought that I was experiencing withdrawal symptoms, even though I knew that's not what I felt. I was also put on a higher dose of Suboxone than I should have been. It made me very sedated, and I was left for 45 minutes, which led to further harm.
In the days that followed, or maybe even, as you said, the weeks that followed, what helped you most?
What helped me most was connecting with my care team in a way in which they seen that I could succeed at being a parent, connecting me with resources I needed to fill gaps. I wanted more than anything to be in a safe place as well as to be a safe space for my child. And so over the next 21 days, I had an addiction medicine specialist that helped me change that tape in my head. And I had other people that were there to support me and show me that, that there doesn't have to be as much of a bridge between what I hope to see and what I can do.
When you say they helped you change the tape in your head, what was the tape? What was it saying?
The tape was, I'm not good enough. I can't do this. I'm not going to be able to meet the expectations of child welfare. Even though like I said, I had been there before and I knew that this would be an opportune time, I still was hearing all of that. And especially when having had the experience that I did after the birth, it led to more shame. And at one point I was like, well, this is my karma for using while I was pregnant, and so it took a long time to change that tape.
Is it fair to say that the stressors, the physical and the emotional pain you were dealing with in those weeks, that they might have led you back into active addiction at earlier points in your life?
Absolutely, yes.
So it actually, in that sense, it seems like a huge win and sort of an amazing thing that they didn't this time.
Yes.
I guess I'm still wondering, why not? What was different about this time?
I wish I could say, because I had gotten a significant time in recovery before, but what led me back into active addiction was deaths in my family and not having the right proper supports around me. So I think just since then I've had the proper supports around me. I also had to experience 21 days in the hospital where, because of the stigma of me being a person in addiction, they overlooked my son's condition of pyloric stenosis, which was actually a very organic thing that happens sometimes for babies, but they had overlooked it as if I was not feeding my child appropriately, and so DHS or CPS was involved with that, and it took 15 days before they realized that they overlooked that he had pyloric stenosis. So even through that, I was able to not return to active addiction. And there's been things in this time around. It's been 5 years. I'm coming up on 5 years in recovery and a year off of buprenorphine, and there's things, the things that I think have kept me here this time is just the actual support that I have and just the knowing of how hard I fought to get here.
As I noted, Diana Smith is with us as well, a certified nurse midwife who works for Project Nurture. Diana, you've described yourself as a midwife who works at the intersection of addiction and reproductive health. Why did you seek this out?
Well, I had been a midwife for a number of years before I came to Portland, and I joined a practice here in town where our clinic had been chosen as a pilot site for Project Nurture because we knew that many women who came to us for care were reporting that they were using substances and wanted access to treatment and mental health supports. I personally have family members who have substance use disorders. My sister had struggled with use during her pregnancy and was a teen parent, and I navigated with her alongside that journey. And so I was compelled to become a part of this work and really to respond to the need that I was seeing in our community. And when I began doing it, I just found it to be like incredibly satisfying work because substance use disorders are chronic medical conditions that we have medications to treat them. We have therapies that work, and we need to build our support system. So within a program like Project Nurture, where people get that wraparound care, we see people succeed.
It seems that pregnancy represents both a serious danger in a number of ways, and also a real possibility for people who are already struggling with substance use disorder. Can you describe those two sides of it, the danger and the opportunity?
Sure. Well, we know that untreated substance use disorder is the leading cause, along with other mental health conditions, of death during pregnancy and the year postpartum. One leading cause nationally, but also the leading cause here in our state. And so it's a complex issue, right? When people are using substances, it affects their bodies physically. It has potential to affect the fetus that they're carrying. Certainly, the stigma and bias and lack of resources prevent people from getting care. And so they can experience a lot of health sequelae related to poverty, living outside infectious disease that comes with active use, right? Very hard on your health. On the flip side, we're talking about reproductive age women, many of whom haven't been long in their addiction and their use. They have often motivation internally and they're compelled to seek care. And when they're welcomed to care, they can be very engaged in working towards recovery. And then there are pressures from the outside system, right? Fear of child welfare and the fear of having their family disrupted.
How would you describe overall the relationship between perinatal or maternal care and the behavioral healthcare worlds right now in general? I mean, I know there's a lot of different versions of this, but broadly, what do you see?
Well, I think the systems have set us up to be very siloed. So pregnancy health care happens over in physical health care, OBGYNs, midwives that are really experts in reproductive health. And then we've got our addiction medicine specialists and behavioral health counselors that operate in our systems of behavioral health care. And often they're not working together and communicating across the system. So you have folks in treatment settings in behavioral health who feel really scared and unprepared to take care of pregnant people.
What are the reasons that they're scared? What have you heard?
Just general knowledge gaps, we don't know what to do. They're worried that maybe they would do it inadvertent harm, or they don't know if the medications or treatments that they use are safe to use during pregnancy. They also just don't have the resources that they need. Not every addiction treatment center has an infrastructure to bring families in. So for people who are parents and have young children, ideally the family would stay together and those young children would come with the parents into that treatment setting.
But that's rare.
There are a limited number of beds, yeah.
So that's more on the behavioral health side. What about on the OB or midwife side? What do you hear in terms of their general understanding of, awareness of, ability to deal with or help people through substance use disorder?
Yes, I think many people did not receive formal education on substance use disorder in their training. So there's a knowledge gap. And then there is unintentional and also overt stigma and bias against people who use drugs and sometimes an attitude of that's just not what we do here. And I think with good collaboration, we really do need more addiction medicine specialists and people trained with those expertise that can partner then with our reproductive health specialists and provide that dual care. But there's also a lot we can do as OB providers and midwives to learn about addiction and at least have an open mind and a welcoming attitude and a science-based understanding of the disease so that we can connect people with the treatment that they need.
If you're just tuning in, I'm talking right now with Sarah Bovee and Diana Smith. Diana Smith is a midwife who works at the intersection of addiction and reproductive health. Sarah Bovee is a peer mentor and doula now for Project Nurture. Sarah, what does your daily work entail now as a doula and peer mentor for Project Nurture?
It's all over the place because I meet clients where they're at, whether that be at the hospital where they've arrived for the first time to have their baby, or whether that be that they've established prenatal care within our midwifery office, or sitting alongside them through intensive outpatient groups that our CADC facilitates. It's a lot of meeting people where they're at with non-judgment and letting my story or my experiences also help guide them and teach them how to advocate for themselves and be consistent with compassion and help them build their autonomy.
What are specific ways that you draw on your own experience as you're helping them? I mean, how does... I guess what I'm wondering is what does it mean to you to be a peer mentor?
It's healing for me. It's healing for them. It's a mutual healing. I've been in dark places, but then I've also made it out of those dark places and have had success. And I feel like everybody deserves that, and everybody deserves dignity. And so as I watch somebody else heal through their journey, it also heals me.
Just last week, we talked to a reporter who had done a pretty deep dive into the nationwide issue of women being referred to law enforcement post-birth after positive drug tests. How much does the fear of either being arrested or losing your children prevent expecting mothers from seeking care, whether prenatal care or support for substance use disorder in the first place? I'm wondering how much the people you're talking to don't seek care because they're afraid of what might happen if they do.
I think it depends on how early we're able to get to them and pair them with support. I meet people sometimes out that have been connected to us through outreach, where they have they currently are living in homeless camps, and they have so much fear about child welfare because maybe past involvement that it makes that to where they end up not even being able to access our supports, no matter how many times I reach out, So there's a lot of fear around that. It's the way that the system treats a person, and by the system I mean all the systems that a person with addiction has to navigate, whether that be medical or child welfare. The way that they hold space for a person with non-judgment and let them have autonomy in the choices that they make really dictates like the trajectory of where that person is able to go as a parent and the healing that they're able to access.
Diana, how does payment work for this, for the kinds of services that Sarah is providing, or the kinds of trauma-informed practices that you want, system-wide people to adopt? In the end, in America, so much of healthcare comes down to who's going to reimburse this, at what level? Will this be reimbursed at all, this care? Will insurance pay for it? Will Medicaid pay for it? What does that look like in Oregon?
This is a big barrier for our program's sustainability and expansion. There isn't a great reimbursement model for this complex care that is integrating behavioral health and physical health care. And so the payment systems are siloed just as the healthcare delivery systems are siloed. And we are working with folks across our state, both on the healthcare system side and the payer side, the CCOs and the Oregon Health Authority and the legislator, to try to solve for this and come up with a value-based reimbursement that really recognizes the positive impact of the care during the pregnancy and the good health outcomes for the whole family lifelong.
You also work with the Oregon Perinatal Collaborative, which focuses more on these kind of questions, policy questions, as opposed to individual healthcare questions, to reduce perinatal mortality and morbidity, including from substance use disorder. What does that policy work look like right now?
Right now, well, a lot of the work that Oregon Perinatal Collaborative does, or the OPC, is to bring community partners together and folks from across the different sectors to do collective problem solving. Right now, we're working on figuring out some guidance for with work groups from the Oregon Health Authority, with representation from people around the state, on recommendations for how to bill for peer services, like the services that Sarah provides in physical health settings, and also really advocating for Medicaid reform.
Sarah, I'm curious what message you would give to people listening right now who are dealing with these issues themselves, dealing with pregnancy and substance use disorder right now. If you were talking directly to them, what would you say?
That there is a way out, that there are people doing work so that you can have a safe space to heal within, and so that you can parent your child if that's what your choice is. But that also, if you have a different idea of what it is you want that's healthy for you, that they will support you through that too.
What would it have taken for you to hear that message at earlier points in your life? Diana, you raised your hand. You want to answer that first?
Well, I want to speak to this common misconception that, like, if the person were stronger, then perhaps they would have been able to achieve recovery sooner. And what we really see with the disease of substance use disorders is that it's very common for people to have multiple attempts before they get into sustained recovery. And it's similar to folks living with diabetes or other mental health conditions, right? That they access care, they try it out, then they might have a stressor and return to their disease state and then recover. So what Sarah described in her trajectory is actually pretty common. I think we need to plan for that, not this idea that on the first try, people are necessarily then going to be able to abstain for the rest of their lives. But that if we have a system that supports families to have the medications, the health care in place, and the supports to make sure they keep their kids safe and get back into their treatment and recovery, then they can sustain that, and they're more likely to get into long-term recovery after a few tries.
And I echo that. Since 2004, I've been working on my sobriety and recovery and sustained recovery, and so I had 8 years before, and even when I went out again, I think that I've learned lessons from both of those times that were very imperative for me for my success now.
Diana, you mentioned families there, and I just want to, before we say goodbye, I just want to zero in on that. I mean, what would a system look like that is more attuned to family dynamics in the context of what we're talking about here, as opposed to an individual?
Well, I think about the things that families broadly need, like respite care, support in the early postpartum period, to support mental health, ensure that people are getting sleep and health care as they need to get through that early parenting window, access to childcare, affordable housing, opportunities for employment. Those things are really, really key. And I think we're moving in the right direction, even within the child welfare system, that they have dedicated teams that work with families, that focus for families with addiction, that better understand that life course and are able to create individualized plans that with the goal of keeping the family unified and supported and healthy and well, and plans in place for when they need that added support.
Diana and Sarah, thanks so much. I appreciate your time. Thank you. Diana Smith is a certified nurse midwife who works for Project Nurture. Sarah Bovee is a peer mentor and doula for Project Nurture.